Welcome to the deep dive. Today we're really getting into something crucial for all you nursing students out there. How our bodies handle blood sugar or glucose and, well, what happens when that system gets disrupted, like in diabetes mellitus.
Exactly. Think of this as a focused look to help you really grasp how the body should normally work, what goes wrong in diabetes, and sort of the foundational ideas behind the medications you'll encounter. We've gone through quite a bit of material to pull out the essentials for you.
Right, and we're especially aiming this at those of you building your core knowledge in those fundamental nursing courses. Our mission here is to make these concepts stick, and show why getting a handle on this is just so vital for your practice down the road. Okay, so where should we start? How about the body's normal baseline for keeping glucose in check?
Sounds good. So fundamentally, our bodies run on glucose. It's the main fuel. And when we've got extra, we don't just waste it. We store it, mainly as glycogen in the liver and muscles. Think of glycogen as like a readily accessible energy reserve for quick glucose release when needed.
And the main player coordinating all this is the pancreas, right? But it's got more than one job, hasn't it?
Precisely. The pancreas is really interesting that way. It's got that exocrine function releasing digestive enzymes, which is vital, but not our focus today. We're zeroing in on its endocrine role. Deep inside the pancreas, you have these little cell clusters, the islets of Langerhans.
Ah, yes, the islets.
And within those islets are different types of cells, each making specific hormones that are absolutely key for regulating glucose.
Okay, so who are the main hormone players in these islets?
You've got the alpha cells making glucagon, the beta cells producing insulin, that's probably the one most people have heard of, and then delta cells releasing somatostatin. These hormones are in this constant sort of dynamic balance to keep blood glucose levels stable.
Let's unpack insulin first then. What makes the body release it and what's its job exactly?
Insulin's primary signal for release is high blood glucose, typically after we eat. But interestingly, it's not just the glucose. Hormones from the gut called incretins, released when we eat carbs, give insulin secretion a really significant boost too.
Okay.
Once it's released, insulin acts kind of like a key. It unlocks cells around the body, letting glucose move from the blood into the cells to be used for energy. But it does more than that.
Right.
It also signals the liver and muscles to store excess glucose as glycogen, tells fat tissue to store fat, and even promotes protein building in the liver. So the big picture effect, it lowers blood glucose.
Okay, so insulin brings blood sugar down. What about when it gets too low? That's where glucagon steps in, I assume.
Exactly right. Glucagon is insulin's counterpart. It's counterregulatory hormone. When blood glucose levels fall too low, the alpha cells release glucagon. Its main job is to raise blood glucose levels.
How does it do that?
Primarily by telling the liver to break down that stored glycogen back into glucose. That process is called glycogenolysis.
Glycogenolysis, right.
And glucagon also pushes the liver to make new glucose from other things, like amino acids. That's gluconeogenesis.
You mentioned incretins earlier, boosting insulin. They sound pretty important in this gut-pancreas communication loop.
Oh, they really are. Incretins, like GLP-1, glucagon-like polypeptide 1, are made in the GI tract when we eat carbs. They do several helpful things. Like we said, they boost insulin release, but they also dial down glucagon release from those alpha cells. Plus, they slow gastric emptying, how fast food leaves the stomach, which helps prevent big glucose spikes after meals. And they even signal the brain promoting fullness, satiety.
Wow, quite a few jobs.
It's a very neat system. But GLP-1 itself gets broken down really quickly by an enzyme called DPP4, dipeptidyl peptidase 4.
Okay.
And that quick breakdown is actually why some diabetes drugs are designed to either act like incretins or block that DPP4 enzyme, essentially making the body's own incretins stick around longer and work better.
So it's definitely not just insulin and glucagon working alone. There's this whole team involved, it seems.
Absolutely. The body's energy regulation is incredibly networked. Think about adiponectin. It's a hormone made by our fat cells, adipocytes.
Fat cells making hormones.
Yep. And adiponectin actually increases sensitivity to insulin, reduces the liver's glucose output, and helps protect blood vessels from inflammation. What's really interesting is that levels are often lower in people with more fat around their abdomen. This kind of highlights why managing weight isn't just about calories, but influencing these metabolic signals too. Low adiponectin can contribute to higher glucose and vessel injury.
That makes sense. So fat tissue isn't just passive storage, it's an active player. What about those endocannabinoid receptors you mentioned in the outline? The name rings a bell, but how do they fit in?
right? The endocannabinoid system. It's involved in lots of things, including energy balance. You find these receptors in key metabolic tissues, fat, muscle, liver, even the brain's appetite centers and the GI tract. Think of them as part of the body's store energy signaling. When these receptors are stimulated, it generally pushes the body towards taking in and storing energy. So maybe increased appetite, reduced adiponectin release, more fat breakdown, but also more storage, less insulin sensitivity, changes in gut motility. It's complex, but the general trend is promoting energy gain. And there seems to be increased activity in the system in obesity.
Huh. It sounds like our bodies are really geared towards making sure we have fuel, maybe sometimes a bit too effectively in today's world. What about stress? The fight or flight response? How does the sympathetic nervous system play into blood sugar?
Good question. During stress, the sympathetic nervous system fires up, releasing norepinephrine and epinephrine. These directly impact glucose. They tend to decrease insulin release. Yes, decrease insulin, while increasing the release of stored glucose from the liver and muscles. They also promote fat breakdown for quick energy. It's all about getting fuel ready now to deal with the stressor. But, if that stress response goes on for too long, it can really mess with metabolic control.
And corticosteroids, like cortisol, they're often linked with stress, too.
They are. Corticosteroids generally reduce insulin sensitivity, increase glucose release from the liver, and decrease protein building. It's about mobilizing energy resources during stress.
And finally, growth hormone. What's its angle here?
Growth hormone is a bit mixed. It tends to decrease insulin sensitivity, increases free fatty acids in the blood, but also promotes protein building. Fluctuating levels can definitely disrupt glucose balance. So, yeah, you can see it's a really interconnected system. Lots of moving parts.
It truly is, like a finely tuned machine. So what happens when this machine goes out of tune, when things shift towards hyperglycemia or high blood sugar?
Well, that happens when either the pancreas isn't releasing enough insulin or the body's cells aren't responding properly to the insulin that's there, that's insulin resistance. When that happens, glucose levels in the blood start to climb. We typically define hyperglycemia clinically as a fasting blood glucose consistently over, say, 126 milligrams per deciliter.
Okay, over 126 fasting. And this high glucose causes problems pretty quickly, right? I remember terms like glycosuria.
Exactly. When blood glucose gets really high, the kidneys just can't keep up. They have a limit, a threshold, for reabsorbing glucose back into the blood. Above that threshold, the excess glucose spills into the urine that's glycosuria.
Sugar in the urine.
Right. And because glucose pulls water with its osmotically active, this leads to more urine production. That's polyuria. All that fluid loss then makes you dehydrated and thirsty, polydipsia.
Okay, so glycosuria, polyuria, polydipsia. But even with all the sugar floating around in the blood, why do people often feel so tired and hungry, the fatigue and polyphagia?
That's a crucial point. Even with high blood glucose, if insulin isn't working right, the glucose can't get into the cells effectively to be used for energy. So the cells are essentially starved, leading to fatigue. And the brain's appetite center, the hypothalamus, senses this cellular starvation and triggers hunger polyphagia. The body thinks it needs more fuel, even though there's plenty around, just not getting to where it's needed.
It's like the fuel delivery truck is broken. What about other energy sources? Does the body start using fats and proteins differently? I recall ketones being mentioned.
Yes, absolutely. When cells can't use glucose properly, the body turns to breaking down stored fat lipolysis. A byproduct of this fat breakdown is ketones. Now, ketones can be used as fuel, but if they build up too much, faster than the body can use or clear them, you get ketosis. And if that progresses, it can lead to metabolic acidosis.
And that's where you might get that fruity breath smell.
Exactly. That's a classic sign of ketones building up.
So it's this cascade of problems. And what about protein?
If the energy crisis continues, the body can even start breaking down muscle protein to get amino acids, which the liver can then turn into gluconeogenesis again. This breakdown leads to increased nitrogen waste products. So you might see an elevated BUN, blood urea nitrogen, or protein in the urine, proteinuria. And critically, breaking down protein like this impairs tissue repair, which is why poor wound healing is such a big issue with chronic high blood sugar.
Wow. So hyperglycemia isn't just a number. It really affects the whole body's metabolism, which brings us squarely to diabetes mellitus. How do we define that condition overall?
Diabetes mellitus is, at its core, a chronic metabolic disorder. It's defined by that persistent hyperglycemia, but it also involves fundamental problems with how the body metabolizes carbohydrates, fats, and proteins. And it's this chronic high blood glucose over time that really causes the significant damage to blood vessels we see throughout the body.
Right. The vascular damage seems central to the long-term complications of diabetes.
It really is. The thinking is that high glucose leads to things like increased reactive oxygen species, those are damaging molecules, and maybe decreased nitric oxide, which is important for healthy blood vessel function. The precise pathways are complex and still being studied, but the link between long-term uncontrolled hyperglycemia and major complications is undeniable.
Can you walk us through some of those major long-term complications nurses really need to watch for?
Sure. Well, atherosclerosis, the hardening and narrowing of arteries due to plaque buildup, happens much faster and more severely in diabetes. This massively increases the risk for heart attacks, strokes, and peripheral artery disease.
Okay, so cardiovascular is huge.
Huge. Then there's damage to the small blood vessels. In the eyes, this leads to retinopathy, which can cause vision loss and even blindness. In the kidneys, it causes nephropathy, damaging the filtering units and potentially leading to kidney failure. And damage to nerves, neuropathy, is very common.
Neuropathy. That affects sensation.
Yes, often starting in the feet and hands, causing numbness, tingling, pain, but it can also affect nerves controlling internal organs. Add to that an increased risk of infections and impaired wound healing, especially in the feet, combined with neuropathy. That's how you get serious foot ulcers that are difficult to treat and can, unfortunately, lead to amputations.
It really underscores why managing blood glucose effectively is so critical for preventing these outcomes. What actually causes diabetes? Is it just not enough insulin?
It used to be thought of more simply, but now we understand it's more like a mosaic of factors interacting. It usually involves some combination of insufficient insulin being secreted by the pancreas, cells becoming resistant to the insulin that is there.
Insulin resistance.
Right. And often the liver starts producing too much glucose. Sometimes early on, the pancreas might even overproduce insulin to try and compensate for the resistance, but eventually it can't keep up, and that insulin resistance often gets progressively worse over time. So yeah, multiple things are usually going wrong.
And there's a link with metabolic syndrome too, isn't there?
A very strong link, especially with type 2 diabetes.
Yeah.
Metabolic syndrome is a cluster of risk factors: abdominal obesity, high triglycerides, low HDL cholesterol, good kind, high blood pressure, inflammation, abnormal clotting, all things that drastically increase heart disease risk. There's definitely a genetic predisposition for diabetes too, and the link with obesity, particularly abdominal obesity, is very well established.
So given this complexity, how is diabetes actually diagnosed? What are the specific numbers or tests clinicians use?
The American Diabetes Association sets the standards. Diagnosis can be made based on a few key criteria, usually needing confirmation on a separate day unless symptoms are severe. These are a fasting plasma glucose of 126 milligrams per deciliter or higher.
Okay, 126 fasting.
Or a 2-hour plasma glucose of 200 or higher during an oral glucose tolerance test where you drink a sugary drink and they test your blood later. Or an HbA1c level of 6.5% or greater.
HbA1c, remind us what that measures again.
Right, HbA1c or glycosylated hemoglobin. It gives you an average picture of blood glucose control over the previous 2 to 3 months or so. Glucose in the blood naturally sticks to hemoglobin in red blood cells. The higher the average glucose, the more sticks. Since red blood cells live about 120 days, the A1C reflects that average exposure.
So it's like a long-term average, not just a snapshot like a finger stick.
Exactly. Very useful, because it's less affected by day-to-day fluctuations and doesn't require fasting. An A1C of 6.5% or more is diagnostic. For managing diabetes, the goal for most people is usually below 7%.
Okay. And what was the last diagnostic criterion?
Oh, right. A random plasma glucose of 200 or higher, but only if the person also has classic symptoms of hyperglycemia, like that polyuria, polydipsia, unexplained weight loss.
Got it. And you mentioned early intervention being important.
Absolutely. There's very strong evidence that for people at high risk or with prediabetes where blood sugar is high, but not yet diabetic lifestyle changes like diet, exercise, and weight loss can significantly delay or even prevent the progression to type 2 diabetes and reduce complication risk later on.
Diabetes isn't just one thing, though. There are different types, right?
Correct. We mainly classify it into type 1, type 2, gestational diabetes, and then diabetes due to other specific causes.
Let's quickly touch on those. Type 1.
Type 1 diabetes is an autoimmune disease. The body's own immune system attacks and destroys the insulin-producing beta cells in the pancreas. So people with type 1 make very little or no insulin and absolutely require insulin therapy for survival right from the start. This also includes a form called LADA, latent autoimmune diabetes of adulthood, which is a slower autoimmune destruction in adults.
Okay. Autoimmune destruction needs insulin. And type 2.
Type 2 is much more common. It involves a combination of that insulin resistance, we talked about the cells not responding well to insulin, and a progressive loss of the beta cell's ability to secrete enough insulin over time. It often develops gradually.
And the other types?
Gestational diabetes is diabetes that develops during pregnancy, usually in the second or third trimester. It typically resolves after birth, but significantly increases the risk for both mother and child to develop type 2 later. Then there's diabetes caused by other things, like certain medications, steroids, for example, or diseases that damage the pancreas, like cystic fibrosis or pancreatitis.
It sounds like for type 2 especially, lifestyle is a huge factor in management and prevention.
Oh, definitely. The evidence is overwhelming. The ADA recommends specific lifestyle goals for people with prediabetes. Aim for at least a 7% weight loss, stick to a healthy, reduced-calorie diet, and get at least 150 minutes of moderate intensity activity, like brisk walking, per week.
What kind of diets are effective?
Several patterns work well. Mediterranean style, lower carbohydrate approaches, vegetarian plans, the DAS diet. The key is finding a sustainable, healthy pattern. Exercise is crucial too. It directly improves insulin sensitivity, helps reduce abdominal fat, and it even lowers the risk of gestational diabetes.
And when lifestyle isn't quite enough to control the blood sugar?
That's when medications become necessary. The goal is to reduce that chronic hyperglycemia to lower the risk of those long-term complications. For type 2, treatment often starts with oral medications or maybe non-insulin injectable drugs. But because type 2 can be progressive, many people eventually need higher doses, multiple medications, or even insulin therapy down the line.
Whereas type 1 always needs insulin.
Always, from diagnosis. And it's crucial to remember, for anyone with diabetes, physical or emotional stress like being sick, having surgery can significantly raise blood glucose, so treatment plans often need adjustment during those times.
We've covered the long-term issues. What about acute, really dangerous spikes in blood sugar? Conditions like DKA and HHS, nurses need to spot those fast.
Absolutely, these are emergencies. Diabetic ketoacidosis, DKA, is more common in type 1. It happens from a severe lack of insulin. The body breaks down fat like crazy, producing tons of ketones, leading to metabolic acidosis. At the same time, severe hyperglycemia causes massive dehydration through that osmotic effect in the kidneys.
So acidosis plus dehydration, what are the signs?
Look for that fruity breath odor from ketones, signs of severe dehydration, deep, rapid breathing, Kussmaul respirations, as the body tries to blow off acid, confusion, loss of orientation, and it can progress to coma if not treated urgently.
Okay, DKA. Type 1, ketones, acidosis. How is HHS different? Hyperosmolar, hyperglycemic state.
HHS is more often seen in type 2. The defining features are extremely high blood glucose levels, often much higher than in DKA, and profound dehydration. But, importantly, there's little or no ketoacidosis.
Why no ketones?
It's thought that people with type 2 usually still have just enough circulating insulin to prevent the massive fat breakdown that drives ketone production, even if it's not enough insulin to control the glucose level itself. But HHS is just as much of a medical emergency as DKA. Both need immediate treatment, usually involving fluids and insulin.
Got it. Both critical, super high sugar, but DKA has the acidosis, HHS mainly extreme hyperglycemia, and dehydration.
Okay, we've talked a lot about high blood sugar. What about the flip side, hypoglycemia or low blood sugar?
Right, hypoglycemia, generally defined as blood glucose below 70 milligrams per deciliter. This can happen from things like not eating enough, or more commonly in people with diabetes, from taking too much insulin or certain diabetes medications. The brain relies heavily on glucose, so the body reacts quickly to low levels.
What does that reaction involve? Initially, you might get some parasympathetic signs, maybe feeling hungry. But very quickly, the sympathetic nervous system, the fight-or-flight response, kicks in. Hormones like epinephrine are released.
To do what?
To raise blood glucose. They stimulate the breakdown of stored glycogen and fat. The pancreas also releases glucagon to counter insulin's effects, and somatostatin maybe to help conserve energy. Sometimes this counterreaction can be so strong, it actually causes rebound hyperglycemia later.
Interesting. What are the key signs and symptoms of hypoglycemia nurses need to recognize? It seems crucial to distinguish it from hyperglycemia.
It is crucial. Symptoms fall into two main groups. Neuroglycopenic, meaning the brain isn't getting enough glucose, can cause things like headache, difficulty concentrating, confusion, irritability, slurred speech, even seizures or coma if it's severe.
Okay, brain-related symptoms.
Then there are the adrenergic symptoms from that sympathetic activation. Think sweating, tremors or shakiness, anxiety, rapid heartbeat, maybe feeling cold or clammy, pallor.
Sweating and shaking are common ones people mention.
Very common warning signs. But, and this is important, symptoms vary a lot between individuals. And some people, especially those with long-standing diabetes, can develop hypoglycemia unawareness, where they lose those early warning signs. That's why if a patient has any sudden change in mental status or behavior, checking their blood glucose is always a good idea.
Definitely a key takeaway. So if someone is hypoglycemic, especially if they can't just eat or drink something sugary, that's where glucose-elevating agents come in.
Exactly. These are medications used specifically to raise blood glucose quickly. Examples include injectable glucagon or drugs like dasiglucagon or diazoxide. And of course, in a clinical setting, giving glucose directly, either orally as tablets or gel if they're conscious and able, or intravenously if they're not.
How do agents like glucagon work?
Glucagon primarily works by telling the liver to rapidly break down its stored glycogen, glycogenolysis, and release glucose into the blood. Some agents might also decrease insulin release.
And when would a nurse typically administer something like injectable glucagon?
Usually in a situation where a person with diabetes has severe hypoglycemia and is unable to safely swallow glucose, maybe they're unconscious or having a seizure. Family members or caregivers are often taught how to administer it at home for emergencies. Diazoxide is used less commonly, sometimes for specific types of hypoglycemia, like those caused by certain tumors.
What are the key nursing considerations when using these agents?
Number one is monitoring blood glucose frequently. You need to see if it worked and make sure you don't overshoot into hyperglycemia.
Right.
If you give glucagon, the patient might feel nauseous afterwards, so positioning them to prevent aspiration is important. You also need to follow up with a source of longer-acting carbohydrates once they're able to eat to prevent the blood sugar from dropping again. For diazoxide, you'd monitor for potential cardiovascular effects like fluid retention or changes in heart rate.
And patient teaching sounds vital, too.
Absolutely. Patients and families need to know how and when to use emergency glucagon if prescribed, recognize signs of both hypo and hyperglycemia, understand potential side effects, the importance of follow-up, nutrition, and consistent blood glucose monitoring. And practically, you always want to have insulin available just in case the glucose-elevating agent causes excessive hyperglycemia.
So if a nurse finds a patient confused and sweaty, checks their glucose and finds it's, say, 45, they might administer glucagon per protocol, then monitor closely, provide carbs when possible, and investigate why the hypoglycemia happened in the first place.
Precisely. That's the core process.
This has been incredibly helpful, really clarifying the whole picture. So just to recap the big points, regulating blood glucose is this really complex dance involving hormones like insulin and glucagon, organs like the pancreas and liver, and even signals from fat tissue and the nervous system.
A very delicate balance.
And diabetes mellitus fundamentally throws that balance off, leading to hyperglycemia, which over time can cause serious damage throughout the body vessels, eyes, kidneys, nerves. Understanding how it all normally works, what goes wrong, and the basics of how medications intervene is just foundational for nursing care.
Couldn't agree more. And as you move forward in your studies and practice, it's worth reflecting on just how finely tuned this system is and how everything we do, lifestyle changes, medications, is really aimed at trying to restore or support that balance for people living with diabetes.
That's a great way to put it. And perhaps a good point to end on, encouraging everyone listening to keep exploring the specific anti-diabetic drug classes and really delve into the nursing implications for each. There's always more to learn. Thank you so much for joining us on this deep dive today. We really hope this helps solidify these essential concepts for you all.